Acute esophageal necrosis, a diagnostic black hole. In this case report, acute esophageal necrosis, or AEN, will be discussed in detail, defining the exact workup, studies, and outcomes in a patient who is admitted, as well as discussing the pathophysiology of AEN. AEN, which is also known as black esophagus, is a rare clinical syndrome that results from low blood flow states and poor gastric motility or obstruction, but guidelines surrounding the appropriate workup of the acute triggering or inciting event are lacking. When not easily identified based on the history, the etiology of AEN should be thoroughly investigated in order to decrease mortality by appropriately addressing the inciting event. In this case, we have a 60-year-old white male with a past medical history of acid reflux and hepatitis C, which have been treated in the past, who presented to the emergency department complaining of hematemesis for 3 days. His only medications were ibuprofen, which he uses a few times a week, and famotidine, which was recently changed from omeprazole. Family history is significant for CAD, diabetes, and hyperlipidemia. He smokes about a half a pack a day for 20 years, as well as has a history of former alcohol abuse, but denies any illicit drug use. Review of systems is positive for unintentional weight loss, as well as malaise, but he's not been experiencing any melena or hematochezia. Initial lab studies showed a normal BMP, as well as a CBC showing a hemoglobin of 15.9, a normal white count, and platelets normal, but on the lower side at 144,000. Hepatobiliary studies were all normal. On arrival to the ED, his vital signs were all normal. Physical exam was significant for the patient appearing frail, malnourished, and thin. He had moist mucous membranes. His heart showed bradycardia with irregular rhythm, but no murmurs, and his lungs were clear to auscultation bilaterally. His belly was soft, with mild epigastric tenderness, and he expressed no rebound or guarding. Upon admission to the medical wards, gastroenterology was consulted, and the patient was started on IV fluids and pantoprazole. Initial EGD performed within the first 36 hours of admission was significant for circumferential necrosis changes at the distal esophagus with abrupt cessation at the GE junction, with about 900 cc's of bolus content suctioned out during the procedure. Due to the risk of perforation, no biopsy was obtained. Given the patient's significant weight loss history, as well as no identifiable factor for this patient's AEN, abdominal Doppler ultrasound was performed, which showed abnormal flow concerning for SMA stenosis. Based off this report, a CT angiogram of the abdomen was performed, which showed the SMA with less than 50% luminal narrowing at its origin, with minimal post-stenotic dilatation. The vascular surgery team was consulted, who recommended ABIs to be performed, which were negative. Additionally, an echocardiogram was performed, which showed normal systolic and diastolic function and no significant valvulopathy. After several days in the hospital, a repeat EGD was performed, which showed repeat evidence of esophagitis, but overall was significantly healed compared to the initial EGD. In Figure 1 on the left, the initial EGD is shown with the mucosal darkening. In Figure 2, you can see the starting point of the mucosal darkening, approximately 20 centimeters from the incisors at the GE junction. Figure 3, also from the initial EGD, shows the duodenum with erythema and erosions diffusely suggestive of duodenitis. The last figure, Figure 4, shows the repeat EGD, which was done prior to discharge, which showed evidence of mucosal healing in the esophagus. Throughout the hospital stay, the patient showed significant improvement on repeat EGD after he was started on the pantoprazole. Given the significant weight loss, nutritional status was addressed with high protein intake to promote further healing. The patient experienced no further gastric outlet obstruction on exam, and he was discharged on twice daily pantoprazole and instructed to follow with his primary care provider for management of chronic medical conditions. The vascular surgery team determined that the luminal narrowing of the SMA was not significant enough to cause this degree of acute esophageal necrosis, and no immediate intervention was required, but recommended outpatient follow-up. The pathophysiology, combining low vascular flow state and abnormal gastric motility, is enhanced with factors that promote mucosal injury, such as malnutrition, malignancy, chronic medical conditions such as diabetes, and or acute exacerbations of those, such as DKA, all promoting acute esophageal necrosis. While this patient did not have a biopsy performed, his initial EGD findings were highly suggestive of acute esophageal necrosis. Although the pathogenesis of AEN has been heavily described in the literature, the exact workup of what tests should be performed when the etiology is unknown is limited. In cases such as this, when the inciting etiologic factors are not easily identifiable, further workup should be performed. Evaluation of splanchnic vasculature stenosis and thrombosis should be considered, which was initiated in this patient with abdominal Doppler ultrasound based off weight loss, looking for SMA syndrome that could be contributing to compression of vessels that may supply the esophagus. Additionally, patients should be evaluated for cardiac arrhythmias such as sinus bradycardia and AFib with RVR to determine if these are contributing to low vascular flow states. Lastly, chronic medical conditions should be examined to determine their pathogenic relevance in order to best promote healing, such as this patient who experienced malnutrition with interventions addressed by increasing protein intake to promote healing long term, as well as looking into factors that can be contributing to abnormal gastric motility, such as gastroparesis, which is yet to be evaluated and is recommended as an outpatient, as well as looking into underlying malignancies via routine age-appropriate cancer screenings, such as colonoscopy. By appropriately addressing the exact inciting event of acute esophageal necrosis, treatment can be better directed towards the treatment of an unfortunately high mortality rate. Surprisingly, though, the mortality rate directly attributable to the AEN complications is only 6%. Thus, by defining the exact cause of the low vascular flow state responsible for a patient developing AEN, there's ample opportunity to direct targeted treatment at the underlying disease and potentially improve the overall mortality rate of AEN.